At this time, it is my pleasure to introduce our next speaker of the morning, Ms. Linda Shelton. Linda will be presenting on the accountable care organizations and the patient-centered medical homes. In the program, we have it looking like these are two very discrete and separate subjects, and in fact, they'll be blended together over the course of the next two presentations. Halfway through Linda's remarks, we've imposed upon her to be able to take a break and allow you folks to get a cup of coffee and a bite to eat, and then she'll finish up the second half after our morning break. Ms. Shelton is a principal in the firm of Discern Consulting of Maryland. She completed her Bachelor of Arts degree at Tufts University, and that was followed by completion of a master's degree in healthcare administration at the George Washington University. Linda has worked on the concepts and recognition of the patient-centered medical home since 2002. This subject that we're just starting to learn about, she has been dealing with and involved in for a decade. She led the implementation of the National Center for Quality Assurance's Physician Practice Connections program, which is the basis for the PCMH recognition process, while working on the Wagner chronic care model and the Bridges of Excellence. At NCQA, she also directed all of the NCQA physician recognition programs. As a consultant, she led a demonstration project for the eHealth Initiative on care coordination and advised Transform Med on synchronizing its PCMH program with the NCQH requirements, among many other projects. Now, as a partner with Discern Consulting, Linda is advising the Maryland Patient-Centered Medical Home Pilot Project, which represents 53 practices in the state of Maryland on their implementation and moving forward. Linda has served as a speaker and task force participant for many national organizations, including the Care Continuum Alliance, the Institute for Health and Productivity Management, the Health IT Summit, and as an expert task force member for the Agency for Healthcare Research and Quality. Ladies and gentlemen, would you welcome from Maryland and Discern Consulting, Ms. Linda Shelton. Linda?
Great, thanks. Well, it's nice to be here with you today. That was a very interesting presentation before mine. I'm going to switch gears a little bit and talk about not so much legislation and rules and rights, but kind of what's going on in the healthcare community now, and particularly on the business end of it. Discern does a lot of work with primary care practices, with state governments, with other kinds of organizations to basically help figure out, first of all, how should the delivery of healthcare change? How should it get better? And how should it be paid for? We can do better in healthcare delivery, and we can certainly do better in the way we pay for it. So unlike the parts of the Affordable Care Act that are still getting figured out and that may be sort of on hold right now, the parts of it that we come in contact with, which have to do with encouraging accountable care organizations and encouraging patient-centered medical homes, those parts of it are full steam ahead. And I think that there are things you can do right now to begin to be part of those activities in your own states, working with groups of providers. I think this is potentially a new and very exciting opportunity for complementary and alternative medicine to become part of the team. I think you've got a lot to say, a lot to tell physicians and hospitals about what you can accomplish and the kinds of things that you can accomplish, the research that was alluded to earlier and that we've included in a paper we've done for the Foundation for Chiropractic Progress. What you can accomplish in terms of making people better for less cost is going to have its day now. And so while you're lobbying the legislature, I would encourage you to also be reaching out to your medical colleagues to become part of the team. So it is a lot of new alphabet soup, ACOs, PCMHs. I see gray hair in the room. You can't see mine, but I'm that old too, and I remember the stampede towards HMOs and sort of where that ended. We're all hoping that what is kind of a stampede towards ACOs is going to have a much better result. So we'll talk about some of the incentives that are driving that, and then what the patient-centered medical home is, and where it came from. I would say to you that both accountable care organizations and patient-centered medical homes grew out of the provider community in the private sector. They're really modeled on integrated delivery systems that exist out there and already show great results in terms of health outcomes and cost containment. So care coordination in the medical neighborhood, that's those of us who work a lot of our time on the patient-centered medical home are also talking about the medical neighborhood and how to bring the medical neighborhood together. And that's where you want to be part of that medical neighborhood. What are the incentives for patient-centered medical homes? What does the medical neighborhood need to make it work better? What can you provide to accountable care organizations and patient-centered medical homes that will be congruent with their goals and interests? And then some of the issues of coordination within the medical neighborhood that don't work so well. So I think we all know that what's often hard for our friends and relatives to understand is that actually best quality health care for a population can cost less than the worst quality. And it's hard to get the world to realize that, but it really is true. You know, preventing problems, maintaining people with chronic disease so that they don't have exacerbations, ultimately improves quality and reduces cost. And then Donald Berwick, in his short but very distinguished tenure as head of the Centers for Medicare and Medicaid Services, came up with the triple aim, which is what we want to do with the healthcare system is improve population health, improve the quality of care, largely influenced by the patient's definition of quality of care, and we want to lower costs. And we can do those things all together. So accountable care organizations, the term was coined within the Dartmouth-Hitchcock group that does a lot of work on the Dartmouth Atlas that looks at costs, takes Medicare data and looks at costs across the country. And what an accountable care organization is it's a group of providers. It is a provider built, driven, and led organization. So it's a group of providers that take responsibility for the medical care, the health care for a prescribed population of patients. That, to me, is the great distinction between an accountable care organization and an HMO. While an accountable care organization does take some financial risk, and there are various kinds of risk opportunities for them, they're not an insurance company. They're an integrated group of providers knit together with good information systems. And the good information systems, I think are one of the things that's going to make the difference between this generation of change in healthcare and the 80s and 90s generation of change, which I think probably ended up not helping us much. So where did the whole concept come from? It came from the integrated delivery systems that are out there now that are delivering better care for less cost. Intermountain Healthcare, Geisinger in Pennsylvania, to some extent the Cleveland Clinic. So the concept is we can build those kinds of integrated systems within a community. It doesn't have to be bricks and mortar. It can be a virtually integrated system. And so we've got providers all over the country now getting together. In a lot of cases, it's hospitals driving this, bringing doctors together into an ACO. In other cases, it's doctors saying we don't want the hospitals to run all these things, let's do it ourselves. So it's very interesting. But their motivation, the motivation for providers, is to change the balance of power between providers and insurance companies and bring themselves more into the forefront of taking responsibility for population health and then being able to benefit from it financially. The hoped for benefit for patients, this is what I spend a lot of my time working on. You know, if we don't get to better coordinated care and more comprehensive care for patients that ultimately does bend that cost curve, we're in trouble. It's all of the benefits of these new modalities have got to drive from that, have got to drive from better care and better coordinated care for patients. So one of the first big targets is, as one of our advisors at NCQA told me, the most dangerous point in the healthcare system, when someone is discharged from the hospital. You cannot imagine how difficult it is to get the right information from the hospital to the doctor, and how many things can go wrong in that transition if it's not knit together with good information, good IT systems, good intentions to coordinate. The patient winds up being put on a different list of medications by his hospital doctor, and then he goes home and he's got the medications that his primary care doctor put him on, maybe that some specialist put him on, and he starts taking those too, and maybe there are a couple of blood thinners in those medications, and you can imagine what happens next. And that's why there's a 20% 30-day readmission rate in Medicare. I'm working with a hospital and integrated delivery system in Northwest Georgia that, for instance, sends a nurse practitioner to the home of every patient of theirs when they're discharged from the hospital in order to actually sort out the medications, make sure the patient is on the right track and is going to be followed up after that hospital stay. They're achieving a 1% readmission rate within 30 days. So, I mean, just imagine the cost savings. And I think there are equal cost savings available in complementary and alternative medicine, and I think you all need to make the case for that. So, so this effort at the ACOs and patient-centered medical homes started in the private sector. The ACA picked it up big time. They have already announced 2 groups of accountable care organizations around the country that are entering into new sort of pilot, but these are big pilots, pilot contracts with Medicare that will provide per patient per month fees on top of fees for service, to provide the support for doctors, nurses, others to actually do that coordination, and to ultimately save costs. There were 32 pioneer ACOs were announced in the first batch. Now there's another group of ACOs that were just announced, I think 3 days ago, another 27. So that's in the 60s around the country, organizations that are taking on these new contracts with Medicare. The Center for Medicare and Medicaid Innovation, has anybody heard of that? And the innovation grants? They have $1 billion to give out in grants to projects to demonstrate new ways of paying for health care and delivering health care. They got 3,000 applications for that $1 billion. Recently said we can't make all the decisions within 2 months. They were going to decide all of them by the end of March. Now they're saying it will be several more weeks. Is that going to stop if the Supreme Court makes the wrong decision? Apparently not. They're full speed ahead. They're on the freight train working to make this work. So will the freight train run into the Supreme Court? I really hope not. And we talked about that a little bit earlier. So payment reform, big part of the Affordable Care Act, big part of what's happening in the private sector. For ACOs, they're putting together new ideas about bundled payment. Jerry mentioned that I worked with Bridges to Excellence. It's now grown into an organization called the Healthcare Incentives Improvement Institute, and it includes Prometheus payment, which you may have heard of, which figures out how much to pay for episodes of care or for periods of treatment of a chronic disease. So ACOs are looking at how can we make healthcare work better so that we're taking responsibility. We get a bundled payment for a hip replacement, for instance. And we'll take that. We'll take the risk of that whole event, and it'll be up to us to keep the patient from having to go back into the hospital because of some, unfortunate happening that we didn't work to prevent. So they're looking at bundled payment, looking at global fees, and the way that we figure out what those global fees should be, and our company is involved in doing that for some organizations. So we look at the rates of potentially avoidable complications. They're huge. It's amazing. The Prometheus payment has used up a database of 4 million people, a claims database, and characterized claims as needed or potentially avoidable. And potentially avoidable is things like readmission for a bleeding episode after surgery, emergency room visits, or hospitalizations for exacerbation of a chronic illness. And for instance, with COPD, approximately 60% of all of the costs of treating COPD are potentially avoidable. So it's very interesting. With CHF, it's more than that. They are looking at and beginning to accept partial capitation and thinking about maybe full capitation. I think they might think about it more if everyone didn't have such a bad taste in their mouth from capitation in the 80s and 90s. What we're hoping for now is that ACOs will be big enough organizations that they can absorb some risk, and that they've got much better information to share among the providers and information about what's going on with their patients, that they can actually coordinate care. Then for patient-centered medical homes, and I'll show you a diagram of a patient-centered medical home. They're looking at, it's basically an enlarged idea of primary care to encompass a team of practitioners and to treat the patient as a whole person. There's a thought. And to bring team members both within the practice and outside the practice, to each person work up to the top of their license, to make their relationship with the patient actually result in better care and better outcomes. So the practices that are there now with patient-centered medical homes, and there are actually more than 4,000 medical practices in the U.S. that are recognized by NCQA as patient-centered medical homes. They are talking to insurers, and the insurers are starting to come around about a capitation fee to actually support the kinds of things that doctors need to do, that doctors and their teams need to do to keep people healthier. So they need to talk to them on the phone. They need to reach out to them. They need to track what's going on with them. They need to do secure messaging. They need to coordinate with other providers, and that takes time. And so insurers are beginning to pay a per member per month fee on top of fee for service for practices that actually function as medical homes. There are also some very forward-looking insurers, like Care First in the DC area, is actually providing care managers, nurses who are trained to work with high-risk patients with multiple medical problems, to actually shepherd them through the system and make sure that balls don't get dropped. And then ultimately, for both ACOs and for patient-centered medical homes, is sort of the holy grail of shared savings. So if we can show that we actually produce care for less money than would be expected, so that our trend is a lower trend than the rest of the medical community, insurers are saving money, and the providers want to share in that savings, and that's beginning to happen. So another thing, this is just a sort of a side note in terms of the triple aim. I'll talk a lot about physicians and medical societies and where they are with some of these concepts, and so that maybe you can sort of get the idea that they're starting to soften up, and I really would like to see you all begin to work together better. But these 9 national medical societies just recently came out with a set of advice for patients called Choosing Wisely. And each of the 9 groups came up with 5 things to say to patients that to encourage people to not just ask for every possible treatment and test, but choose wisely, and actually have the courage to ask your doctor, do I really need this? So 2 of them I wanted to especially call to your attention. The first one from the family physicians and the internists is don't do imaging for low back pain, for uncomplicated low back pain where there are no red flags for the first 6 weeks. So, I mean, that's where your expertise lies. That's one of your most important contributions. And now this, this not doing imaging for low back pain for the first 6 weeks, that has been a HEDIS measure. Do you know what does everybody know what HEDIS is? It's a national set of quality measures developed by the National Committee for Quality Assurance, initially applied to health plans because that's where the data was, increasingly being applied to physician practices. But this has been a quality measure for a long time. Now the medical societies have come out and said, we need to tell the public that, you know, you don't need to have an x-ray for uncomplicated low back pain. We need to do more conservative treatment first. And we'll talk about the practice guidelines that actually include chiropractic. And then the other one is from the radiologists saying, don't do imaging for uncomplicated headache. Well, there you go. I mean, these are really news to a heck of a lot of patients out there. And I think it's great that these medical societies have come out and said this. To what extent it will really get through to the doctor on the ground or to the patient remains to be seen. But I do see it as very much in line with your interests and what you do. That there's beginning to be some information out there, some little sprigs of kind of sprouting plants saying, you know, just because the doctor orders it, just because it's a test that's there, or an expensive medication that's there, doesn't mean it's the best thing for me. So the patient-centered medical home, like ACOs, I think grew out of particular things that were happening in the private sector, and then these 4 primary care medical societies came together and said, this is the way we want to see medicine develop, okay? We want to see an ongoing relationship with the patient, a team of individuals, not surprisingly with the physician as captain of the team, but a team of individuals. The whole person orientation, and with the AAFP recently added to this manifesto, is including behavioral health, which is a great addition. Integrating and coordinating care across the health system, using evidence, using data, becoming data-driven, quality-driven organizations. And as I said before, the presence of much, much better IT. It's not where it needs to be, but it's way better than it was 20 or 10 years ago in terms of giving providers feedback on how they're actually doing and enabling them to be quality and safety driven. Enhancing access. And here's another place you can help. Primary patient-centered medical homes, part of what they do is provide same-day appointments to patients who want them. It's a hard thing to do with so many more people coming into the healthcare system. The Affordable Care Act, I don't believe it's going to be derailed. I think it will bring 30 million more people into the healthcare system, and we don't have enough supply of primary care physicians. So other providers taking on the maximum role that they can is going to be absolutely essential. And that's one of the areas where you can help and as part of the team. And then payment that recognizes the added value. I talked a little bit about some of the payment reform initiatives that are going on now and are part of the Affordable Care Act. So how is it different? Okay, traditional primary care is reactive. I'm there, our office is there. When the patient calls, we provide a visit. We provide the best visit we can, but we provide visits. The patient-centered medical home is proactive. I use data, I track what's going on with my patients. I reach out to them to tell them when they have a need, to see how they're doing, to get feedback. Traditional primary care is internally focused. We're just looking at what goes on within that office. The patient-centered medical home is externally focused and recognizes, as I know you do, that the other 8,000 plus hours per year that the patient is not in your office is also something you want to be concerned with. You want to think about what's going on with your patients in their lives. How are they implementing your recommendations about exercise and diet, for instance? And then instead of being volume-oriented, we want to provide as many visits as we can. It's becoming actually outcome-oriented. Again, having better data, looking at quality measures, determining, what's the actual impact we're having. Care coordination, as I said before, is a big part of the medical home concept, and a big part of the hope for eventually bending the cost curve by doing better coordination, better choice of specialists, better transitions of care, using electronic data in order to facilitate that so that those transitions are smoother. And then specifically medical specialists, and I know you don't consider yourself medical specialists. I think that might be part of the way that you become part of this whole development of the patient-centered medical home and the medical neighborhood. When doctors look at referring to specialists, they look at bringing on another member of the team. So a patient-centered medical home wants to not just send the patient off to a doctor and say bye-bye, and if he ever comes back, okay, and if he doesn't, I'm so busy anyway, who cares? They want to maintain that patient relationship. And so where the relationship turns out not to be so good, next to the down arrow there, is when they refer to physicians and providers who want to be medical homes themselves, and who are very happy, such as maybe cardiologists or endocrinologists are quite happy to have a patient referred to them and just take the patient's hand and go on down the yellow brick road and refer to countless other specialists and become a very expensive case, rather than consulting on what's going on with that patient, making recommendations to the patient and back to the primary care physician. Another thing that is not good about the medical neighborhood is weak ties to primary care. I think that we can thank the last major movement in healthcare towards the gatekeeper model, and I call it ghost of gatekeeper. Patients became very frustrated and dissatisfied with the requirement that they get a referral, and a referral was interpreted as a piece of paper to take from their primary care physician to the specialist in order to get it paid. Created a rift between physicians and patients, left a bad taste in everybody's mouth. So what we want to see on the upside, we want to see agreements among the medical neighborhood. For this is what I'll do and this is what you'll do. And this is where I think you can approach your medical colleagues and say, we're a part of healthcare, and here's the part that we're good at, and here's what the research shows we're good at, and here's where the research shows we can help you bend the cost curve. But it's, in order to succeed in this new world, you and the doctors themselves need to begin thinking as team members. Thinking, that's not a come down, that's not a giving up of your autonomy. That actually is going to help you do more and be an even more vital part of the healthcare system. And doctors, by the way, in the NCQA Patient-Centered Medical Home Recognition Program, one thing that NCQA looks for is the patient-centered medical homes to keep a directory of the community providers that they refer to and actually track what happens when they refer their patients and when they come back, and begin to develop lists of the providers they work well with and the ones they don't, and make their choices that way. Okay, so where are your opportunities in this new world? Well, the patient-centered medical homes, they need capacity. I mean, part of this, the whole delegation development is that they don't have enough capacity. And it's actually kind of, I think the patient-centered medical home principles that those 4 primary care medical societies came out with, pretty admirable. I mean, they didn't have to say, we're going to enhance access. You know, we're going to do better about getting people in the same day, about, you know, doing electronic messaging, about, you know, being better about returning phone calls. They didn't have to do that because we're coming to them. They've got a never-ending stream. They're overworked, and ultimately, this whole system has to work for them too. And it's one thing that is enabling them to begin to see that there are other people in my office and outside my office who can work well with my patients and who can help me get to better outcomes. And I've got to begin to give up a little of that control. So they need to be able to do real teamwork. They want to lower their workload. They feel like they're on a hamster wheel of visit after visit after visit, needing to see 30 patients a day, not having enough time to spend with the patients who need more time. And then in terms of getting recognized by NCQA, a couple of the things that they require that sort of focuses these practices on the patient-centered medical home is that they pick important conditions and develop care plans and care management strategies for those important conditions. And it's usually chronic. There has to be at least 3. And at least one of them needs to be either a behavioral health issue or a lifestyle issue. And there's a lot of encouragement, for instance, for patient-centered medical homes to pick obesity. I mean, to pick smoking, to pick conditions and problems that are ultimately going to break down our health system and ultimately our national budget. To the extent that you work with patients around those problems, if you can get patients to exercise better than doctors can, that's a message they need to hear. They also need good patient experience. They're going to begin to be paid based on measures, and some of those measures are measures of patient experience. So patient survey measures. They need to show good relationships with patients. We know that some of the research around chiropractic shows great patient satisfaction. And as in the previous speaker talked about, you know, patients of chiropractors being the advocates with the legislature for getting chiropractic covered. And then for their incentives, in order to do well in the world of shared savings, being able to actually show that they're bending the cost curve, they need efficient providers. They need to partner with and make part of their team partners who are efficient, who can deal with that episode of back pain, for instance, or neck pain or headache less expensively. And then they need, ultimately, they're going to be rewarded based on how well they bend the curve of total costs. So they're being looked at not for the amount of money that's being paid to them for their office and their internal team's services, but how much is being paid in total costs for the patient. So the patient-centered medical home is looked at as having an influence on keeping patients out of the hospital and out of the emergency room. And ultimately, out of, a lot of high-priced treatment and towards wellness. And I personally think, back pain is just a great place to start. I personally think that the solution to our healthcare problems in this country isn't any one big broad brush policy decision. I think it's a whole lot of smart people like all of us working on one problem at a time and figuring out how to solve it, and then moving on to the other one, to the next one, and getting better as we go along. Low back pain is huge. It accounts for a huge amount of disability, a huge amount of cost. To the extent that, the research shows that chiropractic treatment works for low back pain, that's a message that we need to get out. And then neck pain and headaches, obviously, where you succeed there. And you want to start telling your patient-centered medical home medical colleagues about it. Then ACOs, what do they need that you can provide? They also need lower total costs. They're going to begin to take risk for total costs for a population. So they need to be able to avoid unnecessary care, and also to show that they're lowering the trend in total health care costs. And so they need efficient, effective providers. And the evidence, and I have at the end of my slides a reference for a paper that our company did for the Foundation for Chiropractic Progress that brings a lot of this research together. But the evidence shows that you provide effective treatment at a lower cost with great patient satisfaction. So there's a message there. Those are the triple aims: better outcomes, better quality health care, and lower cost. But still, your medical colleagues haven't quite gotten there with understanding that. And the research shows 75% of primary care physicians, when surveyed, said they have had a patient request a referral to a chiropractor. Only 30% of them actually provided that referral. That's a delta that we need to try and change. So what might improve it? We had some discussions at the break. I really think research on outcomes is going to become a key driver, which it hasn't been in the past. But I think in the future, with better availability of data, I think that the research and getting research implemented sooner is going to become important. So getting those outcomes known, having personal relationships with physicians. I think it's a good time to look up on the NCQA website for physicians who are recognized as patient-centered medical homes, and see if there are any you know in your area. Reach out to ones you don't know. Those personal relationships, I'm sure you know, help to build that teamwork. And they, on the other side, are going to be more motivated. There's some evidence basis for what is a good time to refer a person with back pain to chiropractic. This is from ICSI, the Institute for Clinical Systems Improvement. I apologize for throwing more alphabet soup at you. This is the Minnesota-based organization that produces a lot of clinical practice guidelines. And they've noted a number of things for a physician to consider in referring a patient with back pain. One of the things I think is interesting is providing multidimensional treatment, so not just manipulation, but also exercise and education for the patient. And then the last one is outcomes. What can you show in terms of the percent of patients who return to a previous level of activity after an episode of back pain? So neighborhood construction is happening, and I would really recommend that you get involved. These connections are being built on, I think, much more solid ground than who plays golf together. They're getting built based on data. And to the extent that you have the data, you can begin to build those relationships and become more a part of the team. I think that on the other side, they'll become more motivated to talk to you because of their financial incentives. And I think that this, as I said, will build from a bunch of small problems or not so small problems like back pain, figuring out how to take care of them. I think that the medical neighborhood is going to get built from the ground up. It will also, to a certain extent, be legislated when the ACA comes into effect. But I think that what's happening now, building those teams and those relationships within communities, is going to be what helps us actually move toward the AAA. So this is the white paper that we did. It's on the website of the Foundation for Chiropractic Progress, and includes a lot of the research that I mentioned. So I'm happy to take some questions. Okay.
I don't have a question, I have a point of information. On many insurance carriers, the copay for chiropractors is based on specialist. That's the category we do bear, so it is a specialist category that is good information for the medical community.
Okay, that whether it should be or not, I mean, you know, I mean, you all might think in terms of bundled payment in the future too, you know, or case rates. Yes.
You had mentioned in the beginning that you didn't really want to have to make some of the similar errors that HMOs have made with their implementation. Right. One of the topics or the pieces that I think most needs to be dealt with is actually teaching people to live in a way that's more congruent with how their body's meant to function. Right. And there's just a concern that I have in how you describe the type of care that is provided in these ACOs that seems to be that if we keep filling in all the right holes, that we can actually build a structure on top of that without actually talking about building a structure, just filling in the holes. Like we could go around and say, let's focus on this disease, and this condition, and this condition, and this condition, and eventually we'll be able to get to a healthy person. But
yeah, I didn't actually mean it that way, but go ahead. I see what you're saying.
I'm really curious to whether or not it's actually possible to incorporate more of, well, how do we get people to be as healthy as possible, while also simultaneously having the conversation of, and when you have this condition and this disease and things, you need to seek this type of treatment. Is that even possible in this type of structure? Yes,
it absolutely is possible. I mean, one of the founding principles of the patient-centered medical home is the whole person orientation. Okay, so, and these medical societies have said, we're going to do this. They don't quite know how yet. I mean, it really, this is a new concept. But they're beginning to be trained on it. nurses who do care management and counseling of patients are beginning to be trained on it. I think that whole healthy person orientation is something you all have to give and to contribute. And I think it's extremely important. And let me tell you, in terms of solving one problem at a time, I didn't mean one piece of the patient at a time. You know, I meant applying ourselves to particularly thorny problems one at a time. Clearly, dealing with low back pain, if that's going to be one of the thorny problems, that drives you to why are there so many episodes of low back pain?
Thank you.
People are not healthy. Great, thanks. Yes.
Towards the end of your talk, you mentioned some resources of finding these. Sorry.
Yes.
Towards the end of the talk, you mentioned some resources on finding these organizations.
Yes.
Can you go over that again?
Sure. The accountable care organizations, I can't point exactly, but healthcare.gov, if you go on that website, I mean, that's really tracking everything that's happening with the Affordable Care Act. And the Medicare incentive programs with ACOs are part of the Affordable Care Act, and the Center for Medicare and Medicaid Innovation. So you have to prowl around on that website to find the lists. Then I do know where to find the patient-centered medical home recognized physicians, and that's ncqa.org. And then click on report cards, and then click on recognition directory. And then you can go in and pick patient-centered medical home and your state, and you can get a list of all the doctors who are recognized.
I have one more question also.
Okay.
In your experience so far, are you finding more organizations coming together in one facility for this kind of integrated approach, or is it still individual practices trying to work together?
Well, I think that the ideas came from, as they did for HMOs the last time around, they came from the already integrated organizations like the Cleveland Clinic. It's really hard to build those. I don't think anybody has time to build more of, integrated organizations in one facility. And so they're coming together within a community and knitting together with information systems, which I think makes a huge difference. Thanks. Yes.
Good presentation, thanks. I have a question that grew out of I was shared a stage with a pediatrician who is working to set up his office as a patient-centered medical home.
Okay.
And he made the comment that one of the challenges to him is an integrative medical doctor who uses some different approaches than a lot of pediatricians do. And he found out that the outcomes that he was going to be measured on were it's like immunizations. And he said, what I would really like to see is outcomes that talk about how many myringotomies I'm placing, how many kids with ear infections end up needing to have tubes placed in their ears. That's what we do that's good because of our approach, and that's an outcome. Because
they do less ear tubes.
Exactly. And but that's one of my outcomes. I know that I'm good. This is where I'm serving. It, however, is not what the NCQA is asking me to look at, and a lot of the outcomes that are there aren't actually capturing what.
Right.
So my question is a process one. I mean, how does one actually? I mean, how cumbersome is the process, and where are the points where you can get some of those outcomes shifted or changed?
Okay, that's a good question. For physicians like that who want to be recognized as patient-centered medical homes by NCQA, actually the conditions that they address And the outcomes that they look at are very flexible. So there's a lot of suggestion in those standards around, you need to look at immunization rates and yada, yada, yada. In fact, it would make great sense for a pediatrician, when he's demonstrating his or her ability to be a medical home, to pick ear infections. I mean, that's obviously a huge issue for any pediatric practice. And you know, they could pick that as a condition they're following and show their data. And if they've got data on laryngotomy rates compared with the rest of the world, I mean, that's huge. Now, getting laryngotomy rates made a national measure, that's a cumbersome process. Certainly would be worth doing, but it means suggesting that measure, getting it vetted, bringing it through any one of a number of organizations, including NCQA, that develop measures, getting it approved by the National Quality Forum. I mean, it'd be very worth it.
They can choose it as one of their three.
They can choose it and measure themselves on it, and that's terrific.
And it could be,
and that
could be
works.
accepted as one of the three.
Yes,
basically.
yes, absolutely. Okay, yes,
I'm a student here, so I don't have the experience that a lot of people do have. But I guess my question is it sounds to me like you're saying that we cannot be the patient-centered medical home, because I'm not understanding why we can't be that patient-centered medical home and why we have to be a part of that medical neighborhood.
Right.
So we're allowing medicine to define what we do, and instead of us defining how to treat the whole patient. So basically, I feel like what you're saying is that we are a specialist. I mean, I agree that she even said it. I mean, like I said, I don't have the experience that a lot of people have here, but if we are that specialist, that's fine. But I feel like we should be able to be the leaders of that patient-centered medical home, because, I mean, our university's life's mission statement states that we're trained to be primary care physicians. So if we're trained to be that, why can we not be that leader in that medical home instead of just a part of the medical neighborhood and allowing them to define what we do? Low back pain, neck pain, headaches. We do a lot more than just those three things.
Right, right. I think that is certainly possible. It's controversial. It's something, you know, you will have to work toward. I think that in terms of becoming part of an accountable care organization, you know, functioning as a medical home, you know, you need to show that you can. You need to show, you know, show the data on how you can succeed at that.
Well, to be honest,
well, our paper talks about actually chiropractors as medical homes, and in medically underserved areas, it's a good possibility. In areas where you'd be competing with medical doctors, you know, I'm not sure.
Like I was about to say, is I would rather not define it as a medical home, because I'm not practicing medicine.
Right.
I'm practicing chiropractic. So
well, and that's another big controversy. Is should these be called medical homes?
Yeah, because I mean,
when patients think of that, they think of a nursing home. I mean,
yeah,
plenty
of chiropractors went to jail for practicing medicine without a license. So, my other question was that the medical home, the patient-centered medical home, is to treat the patient as a whole.
Right.
But like as you were saying, it seems like we're referring to all these different doctors. So how is it that this medical home is treating the patient as a whole when we're referring out for individual organs that are being treated? Because like you had a list of specialists.
No, that's a very good question. And the concept is that the medical home doesn't refer as much as your average traditional practice does. Okay, and when the medical home refers, it expects the patient to come back. I mean, unless it's a very, you know, a very sick patient that you decide for whatever reason to sort of to co-manage the patient. Oncology is a good example where the patient might, you know, they're medical home might be their oncologist for a while, you know, when they're in cancer treatment. In terms of letting the medical system define what you do, I don't think you should do that.
I agree.
mean, I think you need to make the case for what it is you do. And yes, it's not just those 3 illnesses, and it is much more integrative, and it is aimed at wellness. And you need to be able to show how you succeed in those areas.
I feel like you said that we have shown that with all of our patients that are satisfied with our care, though.
You have, but you still have that
I understand what you're saying. It's the
reluctance
evidence-based
to
behind
refer.
it. Yeah.
Yeah. Mm-hmm.
I guess, like you're saying, there's just a lot of controversy behind it all still. That
Well,
needs to be
you know,
kind of
it's kind of like
followed
medical
through.
guidelines. I mean, once the research is there and everybody knows, you know, what's effective and what's not effective, and it's incontrovertibly proven, and it's incorporated into medical guidelines, it takes an average of 17 years for doctors to actually use it.
Yeah, I guess
So,
my
I think
position
you're
is
in
that
the
I'm still
17
under the bubble. Like I was saying, is I don't have the experience out in
Right.
the field yet, so
Mhm.
I'm still under that bubble. And I mean, basically, this whole conference is scaring the crap out of me. Because that's honest though. Is, you know, I mean, sure, I'm under this bubble, but you know, when I get out, I mean, do I even want to look to these people? Because, like I'm saying, is that it's
to
basic
what
to
people?
the insurance providers and everything like that. Is, you know, I'm leaning more towards this idea of, you know, if I educate my patients to the idea that what we do is totally different in a separate profession from everything
Right.
else that is medicine.
And they pay for it out of pocket.
100%. That's exactly what I'm saying. Is, I mean,
That you know, I mean, that's a choice you can make, certainly.
sure. All right, thank you.
Okay, thanks. Yes.
I realize we're out of time, but I want to just reflect very briefly on the issue of paradigms, which is inherent in many of the questions he's talking about. For our profession, we're never going to get the research. We're never going to catch up with the research need as far as the clinical data. And the target's moving so fast as
Right.
these new delivery models, service models, and revenue models are put into place. And of course, medicine's dirty little secret is they don't have the data either, but they have the cultural authority. So as this target is moving, and as we are trying to define on our terms the paradigm of optimal neurologic health, a vitalistic context for care, and whole person care in a very different set of parameters, a completely different taxonomy than medicine. The challenge for the profession, and I don't expect you to have the answer yet, the challenge for our profession is how to manage that conversation, introduce ourselves with authority, and then participate and collaborate without the fear of assimilation and being taken over. You know, we in a sense, we have legislatively enabled a seat at the table, but we don't have a lot of confidence and experience as a profession. So much of what we have to learn over the next few years is how to sit at that table with some sense of certainty of what we bring of value, and work to redefine what even the outcomes and the metrics and the measurement indices even have to be in this new model.
Right. And how you have something they need. I think that's, you know, that's important as you take that seat at the table.